Management of a patient with blunt trauma to the chest and breathing difficulty. Blunt chest trauma is a common and potentially life-threatening injury, often resulting from motor vehicle accidents, falls, or sports injuries. It can lead to a wide spectrum of injuries, ranging from rib fractures to life-threatening conditions such as pneumothorax, hemothorax, pulmonary contusion, and cardiac tamponade. Early recognition and prompt management are critical, especially in patients presenting with breathing difficulty. Initial assessment and stabilization. 1. Primary survey, ABCDE approach. Airway. Assess airway patency and secure it if compromised. Look for signs of airway obstruction, e.g., stridor, cyanosis, or altered voice. Intubation may be required in severe cases. Breathing. Evaluate respiratory rate, oxygen saturation, chest movement symmetry, and breath sounds. Hypoxia, diminished breath sounds, or tracheal deviation may indicate underlying injuries like pneumothorax or hemothorax. Circulation. Assess pulse, blood pressure, and capillary refill. Manage shock promptly by controlling hemorrhage and providing fluid resuscitation. Disability. Perform a quick neurological assessment. Hypoxia or hypotension may cause altered consciousness. Exposure. Fully expose the patient to examine the chest for signs of injury, e.g., bruising, deformity, or subcutaneous emphysema, while avoiding hypothermia. 2. Supplemental oxygen. Administer high-flow oxygen via a non-rebreather mask or nasal cannula to optimize oxygenation. 3. Emergency interventions. Tension pneumothorax. If suspected, perform immediate needle decompression followed by chest tube insertion. Massive hemothorax. Insert a large bore chest tube to evacuate blood and re-expand the lung. Prepare for volume resuscitation and possible surgery if blood loss exceeds 1,500 milliliters initially or 200 milliliters per hour over 4 hours. Open pneumothorax. Cover the wound with a 3-sided occlusive dressing to prevent air entry while allowing egress. Insert a chest tube away from the injury site. Detailed evaluation. 1. History and examination. Obtain history of the injury mechanism and timing. Assess for pain, difficulty breathing, or signs of shock. Examine for chest wall tenderness, crepitus, or paradoxical chest movement, suggestive of flail chest. 2. Imaging and diagnostics. Chest X-ray. Essential for detecting fractures, pneumothorax, hemothorax, or mediastinal widening. Ultrasound. Focused assessment with sonography for trauma, fast. Useful for detecting fluid, hemothorax, or pneumothorax. CT scan. Provides detailed evaluation of thoracic injuries, including pulmonary contusions and vascular damage. Arterial blood gas, ABG. Assesses oxygenation, ventilation, and acid-base status. Definitive management. 1. Rib fractures. Pain management. Provide adequate analgesia using oral medications, intercostal nerve blocks, or epidural analgesia to prevent hypoventilation and atelectasis. Respiratory support. Encourage deep breathing exercises or use incentive spirometry. 2. Flail chest. Stabilize the chest wall with mechanical ventilation if severe respiratory distress occurs. Non-invasive ventilation or intubation may be required in severe cases. 3. Pulmonary contusion. Administer oxygen and provide supportive care to maintain adequate ventilation. Avoid excessive fluid resuscitation to prevent worsening pulmonary edema. 4. Hemothorax. Insert a chest tube to evacuate blood. Monitor for persistent bleeding, which may require surgical exploration. 5. Pneumothorax. Treat simple pneumothorax with chest tube insertion. Tension pneumothorax requires immediate decompression followed by tube thoracostomy. 6. Cardiac tamponade. Suspected in patients with hypotension, distended neck veins, and muffled heart sounds, Beck's triad. Perform emergency pericardiocentesis or thoracotomy if indicated. Monitoring and support. Regularly monitor respiratory status, oxygenation, and hemodynamics. Ensure serial imaging to assess resolution or progression of injuries. Provide physiotherapy to improve lung function and prevent complications such as pneumonia. Indications for surgical intervention. Persistent hemothorax or pneumothorax despite chest tube drainage. Significant thoracic vascular or diaphragmatic injury. Life-threatening conditions like tracheobronchial disruption or esophageal perforation. Conclusion. The management of blunt chest trauma with breathing difficulty requires a systematic approach to stabilize the patient, identify life-threatening injuries, and initiate appropriate interventions. Multidisciplinary care involving surgeons, intensivists, and respiratory therapists is crucial for optimizing outcomes and minimizing complications.